Are you able to hear me clearly, ma'am?
Komal ma'am?
Yes, ma'am.
We have a tradition to introduce the speaker and also the international webinar. So please give me 2 minutes.
Oh, that's fine.
So that we will share the screen and then forward it by you.
Sure.
Komal ma'am, can you stop sharing the screen, ma'am? Thank you. A very warm good morning to one and all. We are gathered here on the occasion to attend an webinar on the topic hyperglycemia and its consequences by the speaker, dietitian Komal Deepak Kumar ma'am. The Department of Nutrition, St.Anne's College for Women, is organizing an international webinar for the students of nutrition across India on hyperglycemia and its consequences. The team of Nutrition Department takes pleasure in inviting the nutrition fraternity to join us in the webinar and make it a huge success. Without any delay, I would like to start the proceedings of the webinar. Prayer is place of admitting our need, of adopting humility and claiming dependence upon God. It is an expansion of total faith in the power present within and around us. Prayer is exercise of hope. He fulfills our desires if we call upon Him and acknowledge Him every time, particularly at the beginning of any work. So I request Sri Vanilla MSc first year to offer the prayer.
Proverbs chapter 4, verse 5a. Get wisdom, get understanding, forget it neither, decline from the words of my mouth. Forsake her not, she shall preserve thee, love her, and she shall keep thee. Wisdom is the principal thing, therefore get wisdom. With thee, all getting get understanding. In the name of Jesus, we pray.
Thank you so much, Vanilla. Let us make our program auspicious by lighting a lamp. I request technical support to present the slide of digital lamp lighting. Now, I would like to enlighten about our esteemed college. St.Anne's College for Women was established in 1981 by the Sisters Society of St. Anne's. The founder was Srimati Tripathi Nanamma, a visionary who dedicated her life to enlighten and educate poor young girls. At present, the college has a strength of over 3,000 students and 100 lecturers. St. Anne's College for Women is an autonomous college and has been re-aggregated with A+ grade by NAC in its third cycle. Apart from the gold medals of Osmania University, St. Anne's College for Women has instituted gold medals for the top rankers in all streams, that is BA, BSc, BCom, and PG. St. Anne's College for Women also awards silver medals for proficiency in each subject every year. We all are proud to be St. Anne's students. Now, I would like to invite Mrs. Panikumar ma'am, the Assistant Professor of Department of Nutrition, to address the gathering. Thank you, Aisha. Yeah, if I have to pen words about the department, our vision starts from advancement and application of nutrition science for the promotion of well-being of the society and equipping the students with relevant and substantial knowledge and skills. With the same mission, we work and being the objectives as making the students comprehend the concepts of nutrition, pursue nutrition-oriented courses, and ensure employability. One of the ways of organizing these international webinars and all ways to achieve our objectives. Department of Nutrition was established in the year 1988, offering BSc in Applied Nutrition and Public Health to 30 students in two combination. At present, for the last 35 years, it has grown with respect to number of programs offered, staff, students, and infrastructure. At present, we have 330 students in our department, headed by Dr. Meena Patange, Nasreen Begum, Assistant Professor, Department of Nutrition, myself, Fani, Ruja, Hannah Jessie Francis, Amtul Shumaila as Assistant Professors, Dr. Khushbu Vyas and Dr. Parul Chaudhary. And yes, our students have pioneered in creating nutrition awareness programs in various target groups, attending various conferences, participating in competitions, and of course, winning prizes and many more. At the outset, I would like to also thank our dear sister principal, Dr. A. Vijayarani, for giving us the opportunity to conduct such an international webinars. It's a series actually, and at present we are conducting it on hyperglycemia. Over to Aisha. Thank you. Thank you so much, ma'am. Now I would like to request the technical support to present the green reading slide. Okay, thank you everyone. I would now like to speak about our honorable guest, that is dietitian Gopal Deepak Kumar ma'am. Dietitian Komal Deepak Kumar ma'am is a distinguished diabetes obstetrics dietitian contributing her expertise to the NHS Trust in the UK. With a specialized focus on the intricate intersection of diabetes and obstetrics, she tailors nutritional plans to address the unique challenges faced by expectant mothers with diabetes. Dietitian Kumar collaborates with a diverse healthcare team, actively engaging in clinical care, educational initiatives, and community outreach programs to enhance patient well-being. Her multifaceted role extends beyond individual patient accessible resources. Driven by a passion for empowering individuals with knowledge, dietitian Komal Ma'am contributions go beyond the healthcare setting, fostering awareness and support networks. Her holistic and compassionate approach reflects a commitment to evaluating healthcare standards and improving the lives of those navigating the complexities of diabetes and pregnancy within the NHS Trust. She has completed her bachelor's from nutrition and dietetics and food service management in 2004 to 2007 from Women's Christian College and master's in clinical nutrition from Sri Ramchandra Medical College and Research Institute, that is from 2007 to 2009, and attended University of Chester in MSc Cardiovascular Health and Rehabilitation in 2013 to 2018. Ma'am is a UK registered dietitian with a diverse background in various roles. She has worked as a diabetes educator at Epsom and St. Helier University Hospitals NH Trust, a program coordinator for the BBA Maternal and Fertility Group, and a research fellow at the University of Plymouth. Ma'am has also held positions as a clinical advisory dietitian at Sano, a bank advanced dietitian at Lister Hospital, a senior specialist dietitian at King's College Hospital NHS Foundation Trust, and a visibility research dietitian at the University of Plymouth. Ma'am has also worked as a public health research assistant at the University of Chester, a cardiovascular rehab trainee at Eastbourne District NHS Trust, and a consultant dietitian at several hospitals and clinics in Chennai. Ma'am's experience includes managing a team of 8 faculty conducting e-learning and conference-based continuing medical education and contributing to syllabus formation and improvisation. Now, I would like Komal ma'am to lead forward. Thank you.
Thank you so much. That was an amazing and humbling introduction. Thank you. Yeah, so my passion for diabetes has been long-standing. It started many moons ago. My dissertation with Sri Ramachandra University was in the area of diabetes. That's where the whole love of getting everything holistic started. And it's nice to meet MSc students. Brings me back to those days a little bit. So if you all have any questions which are of relevance to you all, please feel free to ask me at the end of it. It's a pleasure to meet all of you all. And today I will be taking you all to my world a little bit as to how I have understood hyperglycemia and how, we manage it in a practical front as well. Okay, let me just get started. So currently, I'm working as a diabetes obstetric dietitian at Epsom and St. Helier. Predominantly, my job involves taking care of diabetes in pregnancy, but I've also started looking into complex diabetes cases on insulin pumps and also being part of the multidisciplinary team. Yeah. Okay. I also chair the British Dietetic Association Maternal and Fertility Group, and I coordinate diabetes education programs from Panache Health Education. That has been long-standing and is my daughter's twin. So it's been 13 years I, have been on that position and have had the pleasure of coaching 300 plus students in the past decade. So in terms of diabetes, what is our understanding of diabetes? So right from the beginning, if you'll have not been aware of the discovery of insulin, please do go and read up on it. It's quite an interesting journey that it was before the discovery of insulin in the 19th century. Children with type 1 never used to live long enough. And at one point where Banting and Best, who discovered insulin, identified what impact insulin could have, they had a ward full of dying children. And when they started injecting insulin, kids started coming back to life. So that was the room of death of diabetes, which has we've seen so much advancement. People with diabetes today can live normal lives. And in fact, I'd like to quote Dr. Mohan's research here, suggesting that sometimes people with well-managed diabetes have better lifestyles than people without diabetes, because they tend to prioritize and live their life to the fullest. So it's very inspiring to meet success stories in your patients as well, and learn from them the real meaning of what holds priority and what holds importance. So now we have reached to, the hybrid closed loop system, where there is an insulin pump, which slowly delivers microboluses of insulin. And it also talks to your continuous glucose monitor. So it's a beautiful combination, which almost works like an external pancreas. It's a technology, still it has its quirks, and we still need a lot of work that we do, because even if it stops for 2 hours, then a person proceeds to develop diabetic ketoacidosis, which is a severe complication. Okay. All right. So in terms of the global population of diabetes, we know that it has been on the rise with the increasing sedentary lifestyles, and also the kind of lifestyle changes that have come through, it is much cheaper to get foods which are obesogenic than to get foods which are not. And the whole trend has been varying in different populations. Previously, this was known to be a condition of the developed society, but this is sort of, we are noticing a sort of a mixture across all different kind of worlds and socioeconomic backgrounds as well, where the burden continues to rise. What does it mean for India? Yeah. So 1 in 11 adults are living with diabetes. Now, 1 in 2 are undiagnosed. So by the time they are diagnosed, there's a lot of complications people have already reached. So for, in my experience, no 2 patients with diabetes are the same, because when they walk through the door and where they are in the condition makes all the difference of how you're managing them. And there's a lot of economic burden that we notice, just not on the healthcare system, but also on the person. And it captures people in the prime of their life. So the ability for that person to earn, the impact on their family. Even yesterday, I met a lady, she developed type 1 diabetes 19 years ago. She has now a family and a child. And she's already developed, stage 5 CKD. So the burden on the entire family and what impact and the turmoil, financial, emotional, physical, their life choices, they're constantly thinking about diabetes. And there are a lot of research papers which also suggest that minimum of, a person with diabetes has to think 200 things more each day to just manage their diabetes. So it is a full-time job if you think about it. Without diabetes itself, we sometimes feel like, life is overwhelming and we can't sort of cope with it. But with diabetes, it can be a lot more heavy as well. Okay. So we are noticing a global increment in terms of projection of what the impact is going to be. And on an average, there's a lot of expenditure as well, which is huge. So an average diabetes-related health expenditure per person per year is around 1,838 US dollars. So it is quite heavy. So let's go back a little bit to basics, because we are going to brief on hyperglycemia. This is usually an entire coursework. So I've taken bits from the coursework and I will be going through those with you. And so I'll try to do as much justice, but it is definitely just an overview. Yeah. So understanding pancreas, as you all might know very well, are made up of endocrine and exocrine tissue. And the endocrine tissue has the islet of Langerhans. Those produce your insulin and glucagon. Yeah. So insulin, what does insulin do? Insulin is sort of like the key which helps in glucose uptake into the cells. So it is anabolic and hormone. Yeah. So it does help in glucose uptake in the liver, glucose uptake in the muscle, and also provides fat storage into the cells. And when does that happen? When there is more blood glucose in the blood, immediately, after a meal, when the food is digested and carbohydrates are released into the bloodstream by absorption, that's when pancreas release insulin. This is what happens in a normal front, yeah? And when there's a decrease in blood glucose, what happens is the liver then releases glucose from its storage form, which is the glucagon. Yeah. And that happens because of the hormone glycogen. So they work harmoniously to try and maintain blood glucose at a normal level. So hyperglycemia happens when the body has too little insulin or when the body can't use insulin properly. Okay, so there are two specific kinds of types of hyperglycemia that can occur. One is there is a fasting hyperglycemia where blood glucose is greater than 90 to 130 milligram per DL at fasting. This is at least 8 hours of fasting that has to be counted in. And postprandial or after meal hyperglycemia is defined when blood glucose is greater than 180 milligram per DL at after a meal. Okay. Now, both hyperglycemia can have acute emergencies and chronic complications, which I think is very undersaid. Most people associate hyperglycemia with long-standing complications such as, maybe I will get a heart attack after 10 years. Let me live my life now. This is the sort of a conversation that a lot of patients tend to have. But we know that hyperglycemia could have acute complications leading to, fast requirement of critical care as well. So let's brief into it a little bit, what happens. So in terms of diagnosis, diabetes can be diagnosed using either the fasting or the postprandial hyperglycemia, or we can also use something called as HbA1c. Now, this test evaluates, the amount of glucose that attaches on the red blood cells. We know that the lifespan of the red blood cells is around 3 months old, and henceforth, this tells you how the blood glucose control has been over the past 3 months. Okay, so especially, if the patients are trying or clients are trying to come and meet the clinical team, sometimes they tend to do their best lifestyle changes around that time. So doing a HbA1c test really tells us how their management has been over the past 3 months. Now, in terms of monitoring management, HbA1c can give us a good sort of idea, but in terms of, whether or not this is going to be helpful in terms of diagnosis, not in every case. So if you're thinking about cases where, the red blood cells production, shape, or distribution is impacted, such as, in pregnancy, there's hemodilution, or in renal conditions, the production of RBC is impacted, or in sickle cell disease, the shape of the red blood cell is impacted. So the amount of glucose that attaches in it is not necessarily the, standardized for us to find out what exactly those results mean. So in situations like that, HbA1c is not a good test, and doing a fasting and postprandial is sort of good. An oral glucose tolerance test involves, 75 grams of glucose given, and then the postprandial impact assessed, and of course the fasting would be assessed as well. So that would be more of a reliable test when it comes to diagnosis. So type 2 diabetes, what we see is almost like the tip of the glacier. What we see below that is a lot of insulin production because body's developed, insulin resistance. So there will be an overdrive of insulin production, impaired glucose tolerance, dyslipidemia, and hypertension. This is what we sort of name as metabolic syndrome, and it usually comes together. So diabetes doesn't often come alone. Now, there are different kinds of diabetes. 90% odd are belonging to type 2 diabetes. And we are seeing an increment in gestational diabetes, which is diabetes during pregnancy, because there are a lot of factors to this. Lifestyle has an impact. A lot of women are tending to get pregnant a lot later in life, and also a lot heavier as well. Genetic predisposition, all these are factors, and apart from, the fact that there could be genetic predisposition of developing diabetes during pregnancy, such as having GCK kind of diabetes. So, and small predominance of diabetes belongs to type 1. So what's the difference between type 1 and type 2? In type 1 diabetes, there's absolute deficiency of insulin. In type 2 diabetes, there is some production of insulin, but there is more insulin resistance. Okay. There are other kinds of diabetes as well, which are usually under the type 3 banner. Few of the examples would be monogenic diabetes, where there's only one gene impacted, or also, pancreatitis could lead to secondary, problems such as diabetes. So all these sort of can make an impact on how hyperglycemia presents itself. Okay. Why is it important to identify what kind of diabetes a person is having? It's extremely complex and sometimes time-taking as well. Sometimes can be years before we have a proper diagnosis of a person. And it is important because it helps us getting the right approach to get the blood glucose within target. Yeah. Diabetes is quite a marathon, and getting blood glucose under target is important to get the prevention towards its complications, and henceforth differentiating different types of diabetes based on the pathophysiology, symptom profile, and different tests that are involved. It can be quite complex and tricky. So moving forward to complications, I am really only briefing on each topic that you all had sent across in your forms. So apologies, I'm not delving in, but you can always ask me more questions at the end of the session. Okay, so acute complications and chronic complications both are possible when it comes to hyperglycemia. So what happens in hyperglycemia? And there is some amount of insulin production that's impacted. Relative deficiency or absolute deficiency, it makes a difference. What do we mean by relative deficiency? So imagine if somebody's had type 2 diabetes undiagnosed for a long time. There is still some amount of insulin that is being produced, but over a period, they've been having hyperglycemia. There's a lot of hyperglycemia, which means the renal tubules, the renal threshold crosses over, and there'll be excessive urination leading to profound dehydration. So the combination of dehydration and hyperglycemia, prolonged state of hyperglycemia, can be quite life-threatening. We see hyperosmolar hyperglycemic state, this one, in predominantly in elderly and somebody who's had type 2 diabetes for a long time. But we can see it sometimes with acute onset of some sort of infections in type 1 as well, where there is no production of ketones, but it's mainly to do with hyperglycemia and dehydration. Okay. This is life-threatening and requires prompt care and hospitalization in the ICU setting. Similarly, diabetic ketoacidosis, you might have heard about DKA. This is a complication. Predominantly, most type 1 cases are diagnosed after they've developed diabetic ketoacidosis and have been hospitalized with it. Okay, it can be mild, moderate, or severe, and absolute deficiency of insulin sort of kickstarts the situation where the body can't rely on glucose as its source of energy and starts relying more on free fatty acids breakdown. And we all know that there's ketone production when fatty acids are broken down for energy. So there is a lot of ketone production, which can lead to ketoacidosis. And this again is combined, just ketoacidosis in itself might not have that huge an impact unless it's combined with, hyperglycemia. There's ketoacidosis. There's also dehydration that can happen because of the diuresis. So all of these three factors coming together makes it extremely difficult. And this sort of ketoacidosis has multitude of impacts on multiple organ levels and requires prompt treatment, because both of these conditions can quickly progress into a comatose stage. So in terms of management, the first and foremost management would be electrolyte replacement, fluid replacement, and also, in very simple terms, to start on insulin because the body is facing some sort of relative to absolute insulin deficiency. Okay. This next stage would be to find out what would have caused it. Is it type 1 diabetes? Is it type 2 diabetes? What sort of management the person is on, and get them the sort of education and care around managing the diabetes better. Okay, so if it's a known case of type 1 diabetes, and sometimes unfortunately they do have recurrent episodes of hospitalization with DK, it can be that the multidisciplinary team has to meet up and see how to improve their care and which spectrum of diabetes is impacted and what could be improvised. Moving forward to long-term complications or chronic complications. So what you all briefly saw there was the acute complications of diabetes, which is HHS and DKA. Apart from, I just kind of fixed to hyperglycemic complications, we also have acute complications which occur are hypoglycemia, and that's extremely common as well, and that is low blood glucose, but I won't be delving into that today. Okay, so chronic complications of diabetes, this uncontrolled diabetes can lead to damage from head to toe. We all know that it's the leading cause of blindness, and in many countries, it still is the leading cause of heart disease and peripheral vascular disease and diabetic foot. But with increase in use of diabetes technology and continuous glucose monitoring and insulin pumps, diabetes remission programs, all of that, we've successfully steered diabetes away from being the leading cause of heart disease in the UK. So a lot can be done, and there has been this has been an exciting phase to be involved in diabetes care, because we have witnessed a radical shift in the population where there can be an improvement and what difference we can make as advanced diabetes clinicians. Okay, so we know that all of this can happen. So how does it happen? Hyperglycemia doesn't stop with hyperglycemia in itself, has an impact on the vascular system. Okay, can be very atherosclerotic in nature and impacts the vascular system of the body, impacting to development of stroke, heart disease, kidney disease, and so on and so forth. It can also impact the nervous system. Okay, so excessive blood glucose can be detrimental and lead to nervous damage. And we know that the impact on autonomic nervous system and peripheral nervous system are different. So if it impacts the peripheral nervous system, it can lead to neuropathy and aggravate diabetic foot disease and things like that. When it impacts the autonomic nervous system, the nerves that are supplying to the internal organs get impacted in a similar way to what, neuropathy occurs. When it occurs to the internal nervous system, it can lead to problems such as gastroparesis and other sort of situations. So depending on which nervous systems are impacted, it can have an influence. Now, this presents, a multitude of problems, and henceforth, each case of diabetes is quite different in how the management is as well. We know that chronic complications, we can distribute them into microvascular and macrovascular. Yeah. So when it is impacting microvascular, it is more to do with neuropathy, nephropathy, and gastroparesis, vision disorders. Macrovascular conditions such as heart disease, stroke, peripheral vascular disease, which can also lead to ulcers and gangrene and amputations. Other complications of diabetes can include infections, metabolic difficulties, infertility, autonomic neuropathy, and pregnancy complications. My area of research and interest has been towards infertility and pregnancy in the past 5 years. And successfully, I have created a new specialty in the UK, and I've been chair of the British Diabetic Association Maternal Infertility Group. So 2024, I am bringing that coursework to India, and I'd be very glad to, lead on that coursework. And hopefully I'll see some of you all there as my participants. Okay. So I had included some cases here, but I don't know if you're able to chat back or not. It looks like a webinar, so I am going to sort of answer some of these questions myself. Unless if you are able to answer, then if you can chat back, then that would be a useful exercise to have sort of a discussion. Would that be a possibility? There are 41 participants. Is it possible to chat back, or should I continue as a webinar and I will answer the question that is raised here? Okay, so I think I will proceed with answering my own question. Okay, so Mr. X is a 70-year-old man with 4-year history of impaired glucose tolerance. The only other problem he's had is hypertension treated with a small dose of ACE inhibitors, and he's quit smoking 20 years ago. He has no dyslipidemia and has had stress electrocardiograms every 2 years with normal results. He uses no alcohol. He is retired from an office job with government and also presently teaches part-time. Okay. Past 3 months ago, he's been noticing some burning and tingling, and as usual, he's not been feeling that well, and he feels that he's not able to walk as much as well. And yeah. So over here, what we note is he is sort of developing some amount of neuropathy, which is being set in as well. Okay. So diabetic neuropathy, as I said, can occur in the autonomic system that impacts the internal organs such as the digestive tract, urinary systems, blood vessels, and sex organs. And peripheral, it starts with legs and feet. So what we notice in this case is development of peripheral neuropathy. Okay, I am going to send this case across after the webinar to the organizers so that students can benefit from playing with some of the evidence that's available. It's a very interesting case where you can identify if there is diabetic ketoacidosis acidosis or HHS being developed and how you would manage that. So this is the question and this is the answer, which I will be sending across to the participants, because I think you will benefit from realizing how important diabetes management in the acute front is. Okay, so what is the science behind diabetes targets? Okay, why do we say we're trying to reduce HbA1c less than 7%? Is because long-term trials such as the diabetes control and complication trial has demonstrated that maintaining HbA1c around 7 helps reduce the risk of long-term eye, kidney, and nerve complications by approximately 60%. Okay. And also the UK-PDS study showed that long-term complications of type 2 diabetes can be prevented by just not diabetes, high blood glucose management, but also blood pressure management, because we know the metabolic impact of both these conditions happen hand in hand. So intensive blood glucose management and control of hypertension as well helps in reducing complications by quite a bit. So 20% decrease in death related to diabetes, 40% decrease in eye, kidney, and nerve complications, and 40% decrease in atherosclerosis. Sorry. And 15% decrease in heart attack as well. So with every 10 millimeter Hg drop in systolic blood pressure, there's almost a 12% decrease in death related to diabetes, eye, kidney, and nerve complications, and also in heart attack reduction. So every bit matters, okay? Sometimes when they're reviewing clients and patients, they can feel it is quite a turmoil to manage diabetes, and they feel that there's no winning. They're constantly having to do the same thing and they don't know whether they've achieved anything. So every 5% change in time within the range of what it should be makes a difference. And every 10 millimeter Hg drop in blood pressure also make a difference. So small changes, review after review, make a massive difference in that person's life. Okay. And this is just not in terms of hyperglycemia and blood pressure. We also know in the bigger picture, weight management has a huge impact on it. But like I said, I'm quite sticking to the topic that was provided to me, that you were interested in understanding hyperglycemia to a better depth. But yeah, every small change matters is the message. This is quite an interesting diagram. The diabetes is almost like an octopus. Okay, multitude of organs are impacted in how hyperglycemia develops. So from neurotransmitter dysfunction to increased glucose reabsorption, increased lipolysis, decreased incretin effect in the intestine, and decrease glucose uptake in the muscles, which is your insulin resistance, and increase hepatic glucose production, increase glucagon secretion by the pancreas, and impaired insulin secretion. So multitude of aspects could have an impact why hyperglycemia is developed. And henceforth, the treatment also varies. Just not the medical management. The medical management, as you can see it on the screen now, the different sort of OHAs for different situations, what might have led to hyperglycemia. But also the medical management in terms of, what kind of education that person receives and what sort of dietetic impacts there would be with different organs impacted. You could think about it. So somebody with gastroparesis, you'll be managing a lot differently than somebody who's developed CKD. So we know that impact. I am aware that I'm speaking to MSc nutrition students, so it's quite exciting that you can make a massive impact as diabetes educators. And there's studies which show that, registered dietitians can improve HbA1c with an absolute decrease of around 2%. And 1.9 to 2% in 3 to 6 months' time of intervention. So you can make a massive difference in somebody's life in not developing, complications of diabetes, and if they've developed complications, not to have an aggravated lifestyle and improved quality of life and secondary prevention of complications as well. The exciting bit about diabetes nutrition therapy is in type 2 diabetes. If you'll get time, please go read up on diabetes remission. There's a lot that's come up in terms of, it's not called reversal, but in simple terms, we try to get them off their medications and sort of put them at a better spot of where they were before they developed type 2 diabetes. So in type 2 diabetes, remission is a possibility. So please go do read on the remission trials, such as the direct trial and retune trial. It's very, very interesting of what dietitians and diabetes educators can do. So this is what I got a response for the survey. So thanks a lot. And I have tried to sort of stick to some of the questions that you'll have asked me. I felt that most of y'all were aware of what kind of diabetes they are, but not too sure on how to diagnose. You're aware on the causes of diabetes, but not too sure on the medical management. Three main things that I do for a living are, I can monitor patients with diabetes remotely. So there are a lot of softwares out there which help in doing that. There are different education techniques which help in me not getting that burnout, oh my God, what am I trying to achieve here? That sort of feeling doesn't come in. I do support my nurses and doctors with appropriate insulin dosing, appropriate medications. And the key skill is carbohydrate awareness and carbohydrate counting, which is the least that most of you were feeling confident in. So this really brings out what you could be doing, because in a practical industrial front, you are using this the most as dietitians and diabetes educators. So please do find different ways of learning it. And we also do run courses with Panacea Health Education. So please do get in touch if you are keen in learning these practical skills, which will make a difference. Yeah. And of course, as I told you, I'm doing some work now with continuous glucose monitors and pumps as well, which I think the awareness was quite low. So these things make a difference in how gratified you feel as a clinician as well, just not, the impact that it has on your patients. So it's all about us being able to get the blood glucose targets within range, but these are the skills that matter most. Okay. So the usual questions I get from students and healthcare professionals: how to improve compliance. People know what is diabetes, but they're not motivated to make behavior change. How do we get most out of consult time? So I've got 25 patients waiting outside. How do I improve that? And how to get, the patient or client to partner in their care and to tackle, to prevent that burnout, because it can be quite heavy compared to other conditions, because it's a chronic ailment. So it can be quite heavy for the clinician as well to manage patients or clients from that background. So the answer to that, is quite simple. So if you go out there and you can read up this paper, Nutrition Therapy for Adults with Diabetes and Prediabetes, it's quite it breaks down individual assessment of how to take care of their eating patterns, preferences, metabolic goals, and macronutrient distribution. All of that, as a clinician, you will know the answer right away at the end of the paper. But implementation is hard, and it is extremely hard when it comes to diabetes management. As a clinician, you have to work as a team, and you have to use different skills and strategies so that you are able to get most out of the time that you have with your patient. Okay. So skills to think of while, doing diabetes education, it's more the art and the science of it that comes together to improve outcomes and to get better gratification. So if you're managing an adult with type 1 diabetes, you're thinking about initially a healthy eating pattern, exercise pattern, and trying to get, fixed multiple daily injections and a consistent carb planning around that. But it's a lifelong of, living with type 1 diabetes. So that doesn't last for very long, can be very stringent. For example, I could tell you, some of my patients do not want to have a snack at a particular timing. They're not hungry, but because they have taken a certain amount of insulin, they almost are obliged to have that snack at that point. So the trick around that is to give them more carbohydrate awareness and help them to count their carbohydrates better and help in, planning how much insulin dose they should be given so that they don't have to unnecessarily eat in accordance to the insulin. Instead, they give the insulin in accordance to what their lifestyle is. So it can work around their exercise, travel, work, sick day planning, shift working. Think of it. This gives massive flexibility to your patients and clients, and it's a game changer because it makes a massive difference to their lives. Yeah. So these are skills that you are thinking about. With type 2 diabetes, initially you're thinking about some amount of weight loss, if that has been the reason for development of type 2 diabetes. That again, in some cases, we see not a very straightforward presentation of type 2 diabetes. Improving exercise, physical activity, 150 minutes per week make a huge difference. Small behavior changes which are sustainable on a long term. As humans, we are beings of habit, and rather than giving out very big plans for them to make those changes, that sort of can be thought about. And you're looking at the entire cardioprotective mechanism, because what you're seeing in the tip of type 2 diabetes underneath is the glacier. Underneath that glacier is the mountain of metabolic syndrome. So you're thinking about cardioprotective, renal protective, plans and lifestyle changes as well. Diabetes remission, I have already mentioned about that, so I won't go back to it. But the whole idea was to reverse, the fat deposition on the liver and the pancreas with rapid weight loss, which led to, decrease in that fatty liver, and that can have an impact. That's one of the hypotheses that can have an impact on how the pancreas start functioning again. Okay. Please to read up on it. If you're seeing somebody who is pregnant, obviously the targets are different. In pregnancy, they're a lot more tighter and requires increased monitoring. But the good news is when we get the targets within range during pregnancy, there is pregnancy and fetal complication prevention. You're essentially preventing a lot of chronic ailments developed in that child even 50 years after birth. So it's quite an important phase of life. And the most compliant group in diabetes is pregnancy, because as parents to be, humans tend to do a lot more lifestyle changes than what they would do for themselves. So you do it for your child if you don't do it for yourself, isn't it? So this is the most compliant group. But of course, if you're working in the space, you start seeing a lot of difficulties as well that come alongside, because there is a higher predominance of eating disorders and disordered eating as also. So it makes it more complex as well when you're managing these sort of conditions. So as a team, you're required to reduce inertia in progressing with treatment plan. So if you meet somebody with type 2 diabetes and you tell them, okay, come back after 3-4 months and we'll see how you're getting along, that's okay. But in pregnancy and you have a very small tenure and you have to get the targets rather quickly as well. Okay. If you're meeting a child or an adolescent with type 1 diabetes, of course, you're thinking just not about diabetes, but you're thinking about growth and development, you're thinking about planning around school activities, supporting picky eaters, hypoprevention, because that's, I think, one of the biggest fears of parents as well. You educate the village around that child. So advanced carbohydrate counting for the family. And if the child is self-capable, a lot of them are extremely capable. School education, and also when that child becomes an adolescent and steps out to university, then transiting smoothly as an adult as well makes a massive difference. So there's a huge role that diabetes educators can play in this front as well. Okay. So now the traditional mindset that type 1 diabetes affects only in children and adolescents is not true. It can affect in type 1, in children and also in adults, because the onset of type 1 diabetes can be triggered sometimes by infections. It can be environment. We don't know exact sort of mechanism of how type 1 develops. It's more to do with the autoimmune response of the body. After COVID, we have continued to see a huge influx of type 1 diabetes. Could have an impact of the infection as well. We don't know. Okay, so depends on who you're meeting. It makes a difference. Sadly, we are seeing more children and adolescents develop type 2 diabetes as well, which is more to do with insulin resistance. So in their management, you're thinking about portion size control, speed of eating, mindful eating, and increased physical activity and reduce screen time. Okay, so I'll just stop with this final slide because I know it is a timed event in terms of behavior change based on the questions that you had asked me. It's quite a process of what a person might go through to make a behavior change, from understanding that there is a problem. Sometimes your patients come to you where they absolutely don't think diabetes is a problem and they are in denial of it. Helping them becoming aware itself is a good next step. So I think expectation as a clinician of what you have from yourself makes a difference of what sort of outcomes. Earlier on in my career, I used to feel like if they come in with a denial, I have to see them at the next step of making those changes and maintaining those changes extremely well. But that's not practically possible. So even if you happen to take your patient up to the next step, you have made a difference in their journey towards managing the diabetes. Okay. So I will be sending across these slides. There are some things that you could read and how you could individualize your care as registered dietitians as well. This is an excellent infographic from the paper in diabetes care. Okay. There are a lot of advancements made now in management of diabetes, so getting familiarized with the advancements as well. So we have moved to, advanced practicing because, it's no longer the traditional roles of practice, because the main problems that we are facing in diabetes, I think, are disparity and implementation. So there's a lot of disparity. One population can be quite radically different from the other, and the needs would be different in terms of language, in terms of technological advances, in terms of availability of resources, affordability, support systems available. So implementation becomes very, very complex. So I will be sending you all this link as well if you all are keen in joining our courses in 2024. We only have one batch each, which usually get filled up quite soon. So please do let us know if you are keen so that we keep you posted. Okay. Open to questions.
Just connect on Zoom and post your questions in the chat box, or they can come here one by one and ask on the mic. Ma'am will answer. Are there any queries in the chat box? No, no. Any questions, girls? Girls, any of you having any questions can come over here and ask, or else feel free to type it in the chat box. All right, before they get ready with the questions, if any, Komal ma'am, there are, many of us assistant professors, or be it the students and all, they were all engrossed all through in your talk. And one of the faculty is so impressed with you. I believe she attended a CME somewhere back in 2017, and the speakers were, at that time, she was too impressed with them. And after that, it is Komal ma'am's presentation, which has kept me completely engrossed. So our Khushbu ma'am says that.
Thank you. Thank you so much, ma'am. It was quite a wide topic for me to try and cover. So there is a lot of bits which I will send out, and sometimes it can feel quite heavy as well, unless they've gone through all of it. Then I'm more than happy to answer questions. I'll send you all my email address as well if you'll have any questions after. There's a question from Sumaya Fatima. How do we differentiate relative and absolute deficiency? Very interesting question. So beta cells of pancreas produce insulin, and there are two tests that we predominantly do. Apart from, there are other sort of signs, tests that we pick up for diagnosing type 1 diabetes. One of the tests is a C-peptide test. Okay, so insulin is produced from proinsulin. And proinsulin breaks down to one molecule of insulin and a C-peptide molecule. So if there is C-peptide in the urine, that means there is insulin being produced. Okay, because that's the partner in crime. That's one test that we do to assess if there's insulin production. There are, of course, cutoffs of C-peptide because they're beyond negligible amounts of insulin is being produced in this type 1 diabetes as well, to a certain phase, which is called the honeymoon phase of their life. And absolute deficiency is diagnosed when there is not much insulin production at all. The other test we do is we identify if there are any autoimmune bodies which are working against beta cells. Okay, so there are tests to identify that as well. So if both of these tests tell you, okay, there is insulin production and there is no autoimmune bodies that are present, that means it's more to do with type 2 diabetes predominantly, and there's more insulin resistance. Okay. Right. Thank you for that question. Second question, complication of gestational diabetes and what are the chances of diabetes recurring in life? That's my bread and butter. So 50% of gestational diabetes women develop type 2 diabetes within the next 5 years of their life, which is very sad because immediately after childbirth, a mom actually doesn't think about herself that much. So supporting them just not during pregnancy, but also having postnatal care is extremely important. chances of mom and baby both developing type 2 diabetes is extremely high. Yeah. So entire family nutrition is what they need. Family lifestyle change, carb awareness, increased physical activity, all of that has to be advised. Hypoglycemia is extremely common, and exercise can lead hypoglycemia. Right duration and kind of exercise. Type 1 diabetes is a condition where there's no production of insulin. But that should not define how much exercise and what kind of exercise a person should do. They should be free to live their life how they want. And we as educators should educate them on how to manage their there are three things we manage: the insulin dose, the carbohydrate quantities, and kind of exercise, because exercise in itself can have an impact on whether the blood glucose are rising or falling. There are certain kind of exercise which can also increase the blood glucose. So it's not a limitation to have type 1 diabetes. I've got marathon trainers, I've got people who bike entire day. We as educators have to work with them so that they are able to achieve the lifestyle that they want. So chromium, interesting question. I can send you some papers because it's an entire talk in itself. So I will send you out some papers on chromium and exercise impacting blood glucose levels, what considerations. It's the ICE things. ICE is the things that we have to think about: insulin dosage, carbohydrate, and form of exercise. If you are keen on that, there is a paper that I can send you across on that as well. And remission of diabetes is sort of like reversal in very simple terms, but we don't call it reversal because there is a chance, we don't know in terms of long term what their chances are of redeveloping diabetes. So there's quick weight loss that is implied over a period of 8 to 12 weeks, which can reduce the fat deposits on the liver and pancreas, and that can lead to a person getting off their diabetes medications. And that only happens in type 2. There is no type 1 diabetes remission as of now. Day-to-day carbohydrate counting, all of us can do it. Today you can go back and find out how much carbohydrate is on your plate. So please do assess, and you'll understand how difficult that can be. Read your labels, check the portion control. You'll be absolutely surprised. Sometimes these no added sugar snacks as well have a ton of carbohydrate added to it. Bypass surgery of pancreas can lead to prevention of diabetes. So it's called metabolic surgery, and metabolic surgery works on the same line, that there is that quick weight loss which can have an impact on the liver and pancreas fat deposits and can lead to remission of diabetes. Very similar to what lifestyle change can do as well, but in certain cases they do require the surgery. That is a lot of questions coming through. Thank you. If the mother is diabetic in the first pregnancy, what are the chances a second child? GDM happens almost 99% in second pregnancy, hands down. So we start monitoring the subsequent pregnancies early on. We don't wait for 28 weeks test. We do it immediately. Stress and insulin resistance are, of course, interrelated. Cortisol, adrenaline are all hormones which can increase blood glucose. So hyperglycemia can happen with just stress in itself. And so it's a very important factor. Mind has a strong impact on gut as well, and on absorption, retention. The body starts feeling there's a fight and flight sort of response, so tries to retain glucose. So if there was a lion in this room, I know you'll throw stones at me if I tell you that example. It's a very typical college example, but yeah, if there's a lion in the room, your body try to maintain the glucose level so that you can run. Yeah. So if there is a virtual lion in all our lives called stress, we constantly try to keep high blood glucose, which is not a healthy thing. Okay, weight management factor to control both hypertension and diabetes, and dietary strategies for healthy weight. So in very simple terms, it would be a calorie deficit of 500, 700 calories a day. But we know it's not as simplistic as that, and it depends on the individual. And we need to run through a detailed assessment to try and get an individualized plan. Yes, I've answered that. So we know the 5-year data in terms of diabetes remission. We do not know long term. So it might help. So there are some people who maintain that remission, but we don't know long-term data. So if they're taking insulin and the blood glucose is going to a hypo level, and what's the wrong with the diet? Obviously, you'll have to assess and see if they're eating enough. But if the insulin can be reduced, it should be, isn't it? It's common sense. I mean, the insulin dose can be adjusted. It's much more quicker. So a lot of patients tend to have humongous amounts of insulin and expected to eat accordance to that. I am a total believer that that shouldn't be the way. We should be working on the insulin dose and reducing the doses. Okay? Because it's anabolic. Why would you want to cause obesity in those individuals, wanting them to eat more to prevent hypo? So can diabetes type 2 be cured by proper diet? Of course, those are the remission trials. So please read on your direct trial. It's quite interesting, the outcomes. How to deal with someone. So motivational interviewing is a technique where you can interview in such a way that you can make a difference in the way the person's motivated to make those changes. Okay, so that's one of the techniques. There's cognitive behavior therapy. Working alongside with psychologists in your team is also another way. Sometimes it's tricky, and we can barely sometimes keep them safe in terms of not developing acute complications. But it depends on the individual. As healthcare professionals, we are here to help them. But yeah, there are techniques in terms of diabetes education. Maybe on another webinar day, we can go through diabetes education at length. Okay, good. Hyperglycemia, could it affect the peripheral nervous system? And is it possible to reverse the damage? And dietary management of these cases. So getting the blood glucose under control would help in arresting further deterioration of the nervous system, and hopefully there will be some amount which can retrieve back. So I know of patients who absolutely, when they had the first diagnosis, they were like, we couldn't see anything. We had complete blurred vision. And that shows, the nerves supplying to the retina were impacted, but getting the blood glucose back into control, their vision also sort of came back. So there will be some amount which we can reverse the damage. But of course, if there is a cutoff, isn't it, of how far along they have been in terms of their complications. But of dietary management, exercise management, lifestyle management, stress management, all of these factors play integral role, which is what makes it simple and difficult at the same time.
The next question, Komal ma'am, is from Revati.
Yes.
She is also an assistant professor in one of the colleges, because we have got, the group from different colleges. So she asked, now that diabetes reversal is in high, I would like to know how much is it possible?
It is 100% possible in type 2. There are studies done amongst people who've developed type 2 diabetes within 6 years. So early diagnosis, a reversal is very much possible in around 70% of them, as per much of the studies. But there are obviously a lot of different presentations that people present with. Sometimes we have people who are not having any much more weight left to lose. So reversal becomes a difficulty in those cases. And it's more to do with managing and preventing complications in those situations. How to deal with one or more complications, you have to individualize their care.
Yeah, and as you said, that requires a few more webinars if we have to deal with all these. Yeah, thank you so much for answering all our questions patiently.
It's my pleasure, and happy Diabetes Day. I hope that invariably we all manage diabetes as healthcare professionals. Whether you specialize in it or not, you will definitely have somebody with diabetes in your room. So it's good to get the skills so that we feel confident and manage these patients better.
Yeah, few more minutes because there are students who wanted to give the feedback also over here. So may I request a few of the girls to come and give the feedback?
Good afternoon, everyone. I'm Sumaya Abdul Bari, a student of MSc Clinical Nutrition and Dietetics first year, and I'm honored to be here and to be given this opportunity to thank Ms. Komal ma'am for providing us with a deep insight of knowledge about hyperglycemia, its causes, prevention, consequences, and many more with real-time data like surveys, case studies, etc. This insight about diabetes will definitely pave way for us to guide our future patients accordingly with a realistic approach essential in today's fast-moving world, such as in adult type 1 diabetes, fixed MDI and hyperprevention, and in adult type 2 diabetes, 7 to 10% of weight loss, physical activity of at least 150 minutes, and behavioral change, and in pregnancy and lactation as well, with constant monitoring and tighter control. As ma'am said, we are humans are beings of habit. So I hope we use this knowledge imparted by ma'am to inculcate these habits into the life of those in need. Thank you. Thank you.
Yeah, true that. And we believe any habit which goes on for 21 days becomes an actual habit. So yeah, next student who's willing to.
Good afternoon, ma'am. I'm Vajida Samir from NSC first year. Ma'am, first of all, thank you so much for such an informative webinar. And one of the things which I found most interesting was the management of diabetes in children and adolescents. When we talk about diabetes, we mostly it's mostly concerned towards the adulthood. And talking about the juvenile diabetes, them being very picky eaters and they also throw some tantrums. So it was very informative to know how, like, few points on managing diabetes in juvenile diabetes children. Thank you so much, ma'am.
Thank you. Thank you so much for your feedback.
Thank you so much, ma'am, for the amazing seminar given by you. Because carbohydrate counting is one of the most important components in the management of diabetes. We end up looking at the entire calories from fat and other sources and end up eating super free, low calorie, packed foods, considering them healthy. But you have given us a new insight and we will definitely read more about it. Thank you so much, ma'am.
Thank you. Thank you so much.
Okay, thank you so much, ma'am. Now it's the time to propose a word of thanks. The essence of all beautiful and great is gratitude. I deem it is a great honor and privilege to propose vote of thanks on this memorable occasion of International Webinar on Hyperglycemia and its consequences. Let me first start giving the glory to the Almighty God for making today's occasion a resounding success. I express my gratitude to our principal, A. Vijaya Rani ma'am, for giving the opportunity for this department to conduct such an amazing event on this scenario. I, on behalf of the management staff and students of St. Anne's College for Women, extend a very hearty vote of thanks to our beloved speaker, to you, ma'am, for gracing this important work and sharing immense knowledge in nutrition and addressing about hyperglycemia. We all are inspired by your great words. I would like to extend our deep sense of gratitude to the faculty joining us and making the session for more beautiful and lively. My heartfelt thanks to my colleagues, the organizing committee, for their valuable contribution, guidance, and encouragement in all our efforts. Coming together is beginning, keeping together is progress, working together is success. I extend my thanks to the distinguished invitees for their presence and making this event a grand success. I thank the faculty of the college here for the interest shown in attending this international webinar. Last but not the least, and the most important, a deep and hearty thanks to all my dear students and the volunteers for their enthusiasm, relentless efforts, dedication, teamwork without whom this event wouldn't have been so successful. Once again, thank you one and all for being with us for this afternoon. It's been a great pleasure. Thank you so much. I would now request everyone to stand up for the national anthem.
पंजाब सिंध गुजरात मराठा द्रविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you, everyone. Thank you, Ms. Komal.
Thank you. Thank you so much for the opportunity again, Ms. Vinny.
Bye. Take care then.
Bye.
Students can disperse to your classes. Feedback link will be given in the chat box. You all can fill the feedback form and then wait for the certificate.
Girls,